from
Recording
the
in
previous
progress.
guidelines have been updated with a new evidence and new recommendations have been created when supported by the published data. The first concept is about the clinical manifestation and diagnosis of aneurysm SAH. And we know because of the high rate of mortality and morbidity, it is very dangerous to misdiagnosis of aneurysm SAH. The classic clinical presentation of a rupture aneurysm in a weak and early patient is a headache that is sudden onset and immediately reach a maximum intensity. The application of the rule named Ottawa SAH rule is believed to reduce the misdiagnosis. According to an internal study by Perry and his colleague in 2030 that enrolled over 2,000 patients, of whom 132 had SAH. The sensitivity and the specificity of the Ottawa rule are 100% and 15.3% respectively. Ottawa SAH rule make to be in the class of recommendation with B in the level of evidence. To confirm the SAH, no contrast computed tomography is still the first choice in this guideline because of its sensitivity in the acute state of this disease. This is an unchanged subject from the first to this guideline. But the reason of no contrast CT should be interpreted by a board certificate neuroradiologist. This is a new recommendation of this guideline. Performing LP lumbar puncture to diagnose or exclude SAH is a recommendation with a level 1 in the class of recommendation. In patients who do not meet the criteria for application, the Ottawa SAH rule addition work up with the CT, lumbar puncture for central glomerular evaluation is necessary, and the lumbar puncture should be performed from 6 to 12 hours after the onset. The result of the study by Wanton and colleagues in 2022 show a sensitivity of 100% and specificity of 95.2% of LP. And the American College of Emergency Physics provide confirm LP as the following diagnostic study if a non-contrast CT is negative in the patient with high suspicion of rupture aneurysm. Controlling BP blood pressure after the rupture is still a controversial topic. Increased BP variability has been associated with the worst outcome, and excessive BP reduction may compromise cerebral perfusion and induce ischemia, especially in the patient with the evaluated ICP. This writing group recommend a gradual reduction of BP when patients are severely hypertension. That means over 119 to 2000 millimeter mercury, but ensuring strict avoidance of hypotension with mean arterial pressure below 65 millimeters of mercury. In the paper that was published in 2022, the author made a comparison between two therapies of controlled BP in the patient of rupture aneurysm. The first one is in Zulu, the target SBP systolic blood pressure before the aneurysm treatment were below 140 millimeter mercury, but in the arm of ultra an increased SBP were only treated in extremely situation, and the result of the research suggests that an intensive SBP lowering does not decrease the risk of rebleeding and does not increase the risk of DCI compared to the more conservative strategy. And a meta-analysis from China conclude systolic BP over 160 millimeter mercury is more associated with rebleeding than a systolic BP over 140 millimeter mercury. What about the role of tranexamic acid? Ultra study is the largest randomization evaluation of ultra-early short-term anti-fibrolytic therapy in patients with ASAH did not show a significant reduction of the rate of rebleeding and demonstrated no improvement in the function outcome among the patients treated with tranexamic acid and control patient. The routine use for anti-fibrolytic therapy is not recommended because of the lack of benefit. Patients with the aneurysm SAH should undergo repair as soon as possible to reduce the risk of rebleeding, preferable within 24 hours of onset. This is the guidance with the level 1 in the level of recommendation. Open surgery option and endovascular technique have different advantages and disadvantages that need to be carefully vetted for each individual patient because many patient-specific factors, for example, age, aneurysm location, aneurysm shape, the presence of ICH and or IVH should be considered. The 2023 guideline confirm again in the ASAH patient should be planned for treatment by a team of neuroendovascular and neurosurgeon to determine the pros and cons of the treatment according to the patient and aneurysm characteristic. And for the patient with a good grade ASH from the rupture aneurysm of the anterior circulation, the benefit of coiling are better than clipping to improve 1 year functional outcome. I repeat it, 1 year functional outcome, that means the short term. But both the clip and coiling are reasonable to achieve a favorable long-term outcome after the treatment. That is similar to rupture aneurysm from the posterior circulation. Coiling is a first choice of operation. So this advance is at the level 1 in the level of recommendation and B in the level of evidence. With the same level 2B in the level of recommendation, the outer subset for the patient over 70 years, the outcome in the coiling arm and in the clipping arm is similar. But for the young patient be below 14 years, clipping the rupture aneurysm might be considered the valuable mode of treatment to improve the outcome of the patient. Early treatment of rupture aneurysm reduce the risk of rebleeding and facilitated treatment of DCI. There are many meta-analyses and individual series support the outcome of the benefit of early treatment, including in the patient with high-grade subarachnoid hemorrhage. And there are limited study evaluating the intraoperative and anesthetic management of the patient undergoing rupture aneurysm. The all factors that were remarked on include the type of flow of blood, the prevention of hyper and hypoglycemia, and controlling the BP. There are no specific study of hypoosmotic agent in the intraoperative management of the patient. hypoosmotic fluid are generally avoided, whether isoosmotic and sometimes hyperosmotic fluid are favored because they help to manage the brain reduction and ICP in the face of vasogenic or cytotoxic edema. Both mannitol and hypertonic saline have been used to decrease ICP and increase cerebral blood flow and brain reduction. But the optimal intraoperative dose of mannitol in a scenario is going, and they insufficient evidence to recommend which therapy is better than the other. The prevention of intraoperative hyperglycemia and hypoglycemia during aneurysm surgery is indicated. Intraoperative volume status and BP goal are not well defined in surgery. Carefully, BP management need to occur throughout the perioperative period, including in the transportation of the patient. Intraoperative neuromonitoring can be used to evaluate functional brain in a timely manner during the aneurysm surgery. The common method include spontaneous electroencephalography and somatosensory evoke and motor evoke potential. Intraoperative rupture is always a difficult complication, even for the experienced neurosurgeon. Placing a temporary clip is the most common solution in this condition. In this guideline, adenosine appear as a second choice or an assistant way for temporary clipping. Using adenosine for temporary profile, hypotension may be considered to facilitate exposure and aneurysm clip placement in selected situations, particularly in the setting of uncontrolled intraoperative rupture. This recommendation make level 2B is the level of recommendation. It is not too bad for a new recommendation at the first time. Adenosine is contraindicated in patients with sinus node disease, second or third degree atrioventricular block, and pulmonary disease. Caution should be used in patients with first degree atrioventricular block, a history of heart transplantation. The dose of recommended for adenosine is 0.3 to 0.4 milligram per kilogram. It will achieve approximately 45 seconds of profound systematic hypotension. This dose can be repeated about 3 or 4 times. Cerebral vasospasm occur frequently in patients with rupture aneurysm, and it associated with DCI and infection. DCI occur in about 30% patients between the day 4 to 14 after the onset. Diagnosis of DCI can be challenging, and although serial neurological examination are important, they are limited value in the patient with high-grade ASAH. The most commonly valuable technique include TCD, continuous ECG, CTA, or CTP. CTA and CTP can provide a valuable assessment for vasospasm after the rupture and the guide treatment decision. The high sensitivity of CTA for detecting vasospasm is about 19%, and with false positive is only 5%, making it a reasonable option for vasospasm detecting in patients with high-grade ASAH. And also CTP allow early prediction of perfusion abnormality and can aid in the detection of alteration of the microcirculation. And CTP has a positive predictive value of about 67% for DCI. TCD, transcranial Doppler, is a non-invasive, safe bedside neuromonitoring technique. Most of the public research has focused on MCA vasospasm, usually defined as a mean CBF velocity over 120 centimeters per second and Linda ratio over 3. Retrospective observation studies suggest that the combination of ECG and TCD provide the best prediction of DCI. In this guideline, the writing author took note of invasive multimodal neuromonitoring, a new approach that has increasingly been used to detect DCI in high-grade subarachnoid patients. For example, BTT02 has been found to help in the early detection of DCI and brain hypoxia. Cerebral microdialysis monitoring may detect the metabolic changes in the extracellular fluid associated with ischemia. This recommendation of stay at 2B level in the level of recommendation in this guideline. Now we talk about how to manage cerebral vasospasm and DCI after the rupture. Nibodipine, maintaining evolemia, elevating SBP, and using the intra-arterial vasodilator and cerebral angioplasty are the factors that were marked by the author. Among us, intra-arterial vasodilator and cerebral angioplasty are two new recommendations in this guideline. The benefit of the medication for DCI prevention and improved functional outcome and the comparative advantage or risk require the future study. Using statin, routine use intravenous magnesium and prophylactic hemodynamic augmentation to improve outcome is not recommended. And now, nursing care. Nursing care is a new chapter in the 2023 guideline. Nursing care activity assessment and intervention for patients with ASAH are initiated at the time of the patient arrival and continue throughout the patient hospital stay and recovery. Expert nursing care is a backbone and pillar for critical care intervention in preventing medical complications and maximizing the chance for the good functional outcome. Furthermore, nursing activity provided by the certificated and competent stroke trained nurses are subject to have a possible impact on the patient outcome. With the 4 recommendations in the level 1 as the level of recommendation, the author confirmed deeply the role of nursing care in the team of management the patient of rupture aneurysm. And now we conclude about the take-home message. The management of ASAH in the hospital is neurocritical care unit, experience of high case volume, expert nursing care, and multidisciplinary team. Prompt evaluation, identification of aneurysm source, and treatment within 24 hours are recommended. Medical complications in multi-organ system are associated with the worst outcome after the rupture. Delayed cerebral ischemia should be detected early by TCD, CTA, or CTP. Continuous ECG and invasive monitoring may be useful in the patient with high-grade aneurysm subarachnoid hemorrhage. Elevating the BP and maintaining evolemia in the patient with systematic DCI can be beneficial in reduce the progression and severity of the delayed ischemia, cerebral ischemia. A multidisciplinary team approach to identify the discharge needs and design the rehab treatment is recommended. Thank you for your attention. Thank you. Can you hear me?
Okay, thank you, Kian.
Yeah. I stopped sharing my screen.
Yes, thank you very much. And now I would like to present Dr. Kương, that's right?
Yeah.
Kương, are you ready?
Yeah, I'm ready now.
Yeah, okay, please. Yeah, Kương, we talk about the vascular embolization. Please, Dr. Kương.
Yeah, I will start my sharing my screen now.
Yeah.
Let me repeat.
Okay, that's good, please. I see. So, yeah, okay.
Yeah, thank you. Good evening, everyone. Let me introduce a little bit of myself. I'm Kương Trần. Currently work at the Grad Center of my hospital as a radiologist as well as a neurointerventionist. And today is such an honor for me to be here and have a chance to talk with you about an interesting topic, endovascular treatment in cases of giant intracranial aneurysms. As far as we know, a giant aneurysm is defined as an aneurysm with a diameter of 25 millimeters or more. They comprising about 5% of all intracranial aneurysms and mostly present between the 5th and the 7th decades, and they are slightly more common in female. The natural history of giant aneurysm is unfavorable. The rupture risk increase depending on each size, and the natural history of a giant aneurysm is characterized by progressive growth, thrombosis, and rupture. Rarely giant aneurysm present with hemorrhage, and therefore many are reviewed by neuroimaging performed for headache, seizure, stroke, or progressive focal deficit. And the risk of rupture of untreated unruptured giant aneurysm is about 8 to 10% per year, and with a mortality of 65 to 100% at 1 to 5 year follow-up. And therefore, surgical and endovascular treatment is the most appropriate option in most cases. Giant aneurysms are histopathologically distinct and most commonly represent circular cerebral aneurysms, but may also be fusiform or serpentine in morphology. They are thought to develop via two pathways. The first one is internal elastic lamina de novo defect, and the second one is enlargement from a smaller one. Giant aneurysm, if left untreated, have an extremely poor natural history with high grades of morbidity and mortality than smaller one. A retrospective review of untreatable giant aneurysm revealed an 80% risk of death or severe disability within 5 years of presentation. And in another prospective natural history study, patients with unruptured giant aneurysm had a 5-year cumulative hemorrhage rate of 40 to 50%. And subarachnoid hemorrhage occur in 25 to 35% of patients on presentation, and thrombus formation within these giant aneurysm may result in ischemic event. About the location of giant aneurysm more frequent in the carotid artery, especially in the cavernous sinus segment, and in the posterior circulation, the basal tip is the most frequent location. About the radiographic tool, we have CT, MRI, and VNSA. The CT scan can be obtained easily and rapidly at most centers, and so we often the first study to when one suspect subarachnoid hemorrhage. And the CT scan can also provide excellent visualization of calcification, and the quality of CT angiographic has improved over the past few years and provide excellent information about the size and configuration of the aneurysm dome, aneurysm neck, and associated vessel as well. MRI remains an excellent tool for evaluating the true size of the aneurysm dome, because as the imaging modalities visualize only the intraluminal dimension of an aneurysm, and so may underestimate the true size of the lesion, especially when there is thrombus inside the aneurysm. MRI can also demonstrate the presence of edema or an ischemic event in the surrounding brain parenchyma. Despite the rapid advance of other imaging modalities, digital subtraction angiography, or DSA for short, remains the gold standard for evaluating aneurysms. This test provides detailed information about the aneurysm neck, associated perforators, and the surrounding vascular anatomy. It furnishes information regarding the presence or absence of collateral flow and the suitability of intracranial and extracranial vessel for bypass. A balloon occlusion test can be performed via DSA as well. Treatment of giant aneurysm can be challenging, and the size and complexity of these lesions compared to smaller ones result in higher treatment morbidity and mortality. Problems can be anticipated in the presence of thrombus, plaque, or calcification. A thorough evaluation and understanding of the collateral circulation across both hemispheres and from the external circulation is will reveal several options for excluding the aneurysm. There are some images illustrated giant aneurysm on NCT, non-enhanced CT, and a 3D VR CTA. The image show MRI show suggest a thrombus inside the aneurysm and the parenchymal edema surrounding. Here another image with a sagittal T1 sequence. So a giant aneurysm in the midline that compress thalamic, hypothalamic, and brainstem as well. And DSA show a giant aneurysm at the bifurcation of the right ICA. About treatment options for giant aneurysm, similar to another aneurysm, intracranial aneurysm, we have surgical treatment or endovascular treatment. On this presentation, I will focus on endovascular treatment. About endovascular treatment, we have several choices such as parent vessel occlusion with balloons or coils, or selective coil occlusion sparing the parent artery assisted by balloon or stent, because The giant aneurysm, as we know, usually had a wide neck. We have some other choice such as selective occlusion with onyx or pen-vessel occlusion after bypass surgery, a combination of endovascular and surgery treatment. And so last one, we have flow diverter stent placement. About pen-vessel occlusion. Pen-vessel occlusion, when tolerated, is an appearing technique. It is simple to perform, safe, and definitely exclude the aneurysm from the circulation. Pen-vessel occlusion can be performed on the ICA, the VA, or proximal basal trunk, and on intracranial vessel distal to circle release as well. About ICA occlusion, the patient must pass the balloon occlusion test first. About the balloon occlusion test, in our opinion, supported by other authors, the angiographic test occlusion is a protocol of choice. The VA occlusion, a giant aneurysm which located on the intradural V4 segment between the pica and vertebral junction. Vertebral junction usually caused by dissection and can safely be treated by internal coil trapping. In this way, the whole vertebral segment, including the aneurysm, is occluded with coils. The contralateral vertebral artery will provide flow to the basial artery. Meanwhile, the ipsilateral vertebral artery supply for the pica. Aneurysm located on the basal trunk or vertebral basal junction in the past has successfully been treated surgically or endovascularly basal occlusion. However, nowadays, with the availability of intracranial cranial stents, the aneurysm can now safely be treated with sparing of the pen vessel. So a pen vessel occlusion technique are no more indicated for this aneurysm frequently. About coil embolization, selective endovascular occlusion of giant aneurysm with sparing of the pen vessel can be achieved by filling the aneurysm lumen with detachable coil. In patients who cannot tolerate pen vessel occlusion, the balloon occlusion test failed. Selective endovascular treatment is a valuable alternative. Selective coiling of a giant aneurysm differ in several aspects from coiling of smaller one because, as we know, most giant aneurysm have wide neck. So therefore, supporting devices such as balloon or stent are often needed. And with time, most aneurysms reopen by coil compaction. So why is coil compaction so frequent in giant aneurysm? From study concerning packing index, is the ratio of inserted coil volume over the aneurysm volume. We know that most aneurysm packed for approximately 25% or more remain stable at follow-up, and less packing means reopening is more frequent. Although on radiographic examination, the aneurysm may seem tightly packed with coils and completely occluded. Calculation of packing index often prove disappointing result in case of giant aneurysm. Despite the use of thick, soft, or complex shaped platinum coils, high packing density can hardly be achieved in giant aneurysm. Therefore, we consider selective coiling of giant aneurysm just as a stage treatment with ongoing follow-up and additional coiling when necessary. Embolization with onyx. Recently, filling the aneurysm with onyx has been proposed as a treatment for aneurysm. With treatment, the neck of the aneurysm is sealed with a balloon during onyx injection, and onyx is an type of bioglue. Although some single-center studies show slightly better results, in our opinion, the high complication rate and high rate of delayed carotid artery occlusion do not justify this treatment in patients with unruptured aneurysm. And in our center, we do not perform this technique. About the flow diversion stand. Flow diversion is the newest endovascular technique specifically fundamentally designed for the treatment of giant aneurysm. Flow diversion stand is fundamentally based on two concepts. The first is the placement of a high-density mesh device in the parent vessel, disrupt blood flow into the aneurysm, resulting in progressive intra-aneurysmal thrombosis. And the second one is the device provides a scaffold which endothelial cell can grow to isolate the aneurysm from the parent artery with a subsequent radiographic obliteration of the aneurysm. Here is the image illustrated flow diverter stand were deployed cover the giant aneurysm with wide neck. Here the image shows the before and after intervention of deployment flow diverter stand. We can see a significant reduce of blood flow into the aneurysm post procedure. We can compare before and after. Here the same before and after, a significant reduce of flow. And now I would like to share with you guys some interesting case. The case number one is A2 fusiform aneurysm unruptured. The patient admitted with symptom headache for 15 days, and MRI show a benign carcinoma in left temporal lobe. The top sequence show a giant aneurysm in LA2 ACA with the size over than 30 mm. A giant fusiform aneurysm in LA2 ACA with a partial thrombus. Here's the DSA belong before intervention. We can see clearly here is a aneurysm. And here is a 3D rotation, so more detail about the aneurysm. We can see here the parent vessel diameter quite small. It's just 1.5 to 2 millimeter. And here is stenosis and the thought just kinky the parent vessel. With this unruptured aneurysm, we had two plans in our mind. The first one is flow diverter stand acid coiling if needed, and the second one is parent artery occlusion. Of course, if the balloon test occlusion was positive. As first, we try to plan one. We try to deploy two stand of flat to aim to cover the parent vessel segment that includes the aneurysm, but failed due to stenosis here and the tortuous structure of the parent vessel. So we change the strategy to plan 2. Here is a occlusion test was performed, and we can see there are the presence of a collateral flow via the leptomeningeal perforator via the MCA on the same side. Then after that, parent artery occlusion were performed with a total of 53 coils, and the final result quite excellent. The aneurysm as well as the parent vessel were excluded over the circulation, and we can still see the ACA territory were filled via the perforator here, and no neurological deficit the day after, and the patient recovered well. Case number 2 is giant aneurysm with stand migration. It's unruptured giant PCOM aneurysm on the right side. here the 3D rotation of the aneurysm. The beyond VNSA before intervention, and we aim to perform a flow diverter stent placement first. Here we can see kinky aorta arch is makes it difficult to access the CCA, right CCA. We had to use ankle technique with 3 coaxial with 6S benchmark, 5 Frank Simon, and we through the velocity delivery character, we temporarily deploy a stent solitaire in ECA to access to ICA by ankle technique. Here is a benchmark tip at the C2. Here is the echelon tip and just wide inside the aneurysm in case of coiling if needed. And here is a headway in M1 segment to deploy the flow diverter stent. We try to deploy 2 stents. First one is P60, P64 stent, and the second one is a press stent to fully recover the parent vessel segment. And here is the final result. Quite good, a significant reduce of the flow, and but after 6 days with control CT scan, we can see stent migrated into the aneurysm, and therefore the second intervention is needed to repair. The second intervention, firstly, we still try to deploy another fresh stent, but failure. So we change our mind to parent vessel sacrifice, and therefore we perform balloon occlusion test first. And luckily, the result of balloon occlusion test were positive. You can see the presence of collateral circulation here. And then parent artery occlusion with 24 coils in total. The MRI after 1 day show some small ischemic lesion with a watershed modality, maybe due to the lack of flow. About the clinical symptom, just a little weakness of the left hand. After 1 month, a start of visual recovery and a little weakness of left hand. CT after 1 month, MRI after 3 and 6 months, showing a stable occlusion of the right ICA and the aneurysm as well. Case number 3 and the last case is a wide neck acorn aneurysm rupture. Here is a CT and CTA of this patient. And rupture acorn aneurysm lead to hemorrhage in ventricle and parenchymal as well. The beyond DSA, we see here is an aneurysm arrive from the left side, and they are absent of the A1 segment on the right side. Is hypoplasia, and in this patient clearly we cannot perform parent vessel sacrifice, and we have to conservative parent vessel in this case. And in this case, we do selective coiling embolization with assisted by balloon. Here is a balloon to remodel the neck of the aneurysm. Here is the first coil without the balloon inflated. It is a small protrusive stent, so we withdraw the coil and recoiling with inflated balloon. Everything seems better. And with the first frame coil, the upcoming coils are way more easier, and 10 coils we're using in total. The final results, quite good. And the MRI after 6 months, the result is quite promising. Yeah. And a quick recap: vagina aneurysm have a poor natural history with high risk of subarachnoid hemorrhage or progressive symptom of mass effects. Treatment of vagina aneurysm were challenging, and several endovascular techniques may be applied for treatment depending on location, size, anatomy, and presence of collateral circulation. And it is the end of my presentation. Thank you so much for the attention. Yeah.
Okay, thank you very much, Dr. Kương. Okay. Now I would like to invite, first I would like to invite Dr. Hiệp. Can you hear me? Yep.
Yes, but as like usual, I prefer to speak later, please.
Okay. Now I would like to invite Professor Trần Anh Tuấn, please. Tuấn, can you hear me?
Hi, Professor. I'm here.
Okay, hi. Please, yeah.
Okay. Thank you for inviting me for participation in the webinar. I have to comment firstly on the giant aneurysm treatment of the Dr. Kương from my hospital. As you know, the giant aneurysm is a big aneurysm. It's also a big problem for the treatment for neurosurgeons or neurointerventionists. We know that we can treat the giant aneurysms with coilings, but balloon assisted coilings, stenting, flow diverter, and the last choice is power artery occlusion. And but the coilings in the giant aneurysm is not bad because the recanalization after treatment is very high. Most of them will recanalize. So it's my opinion. The first choice is balloons. It's power artery occlusion and flow diverter direction, because we know that the big aneurysms have mass effects on the parenchyma, and Perry's aneurysms edema is very high. So when you use the coilings inside the aneurysm, you cannot reduce the size of aneurysm. But the power artery occlusion and flow diverter stenting, flow diversions can reduce the aneurysm after 3 or 6 months after treatment. So it's my hospital, I prefer for power artery occlusions and stent flow diverter. The second comments on the presentation of Dr. Kiên, I agree with Dr. Kiên that we need to treat the aneurysm within 24 hours. Same guidelines now, because the rebreathings of the aneurysm is very high in the after first rupture, first time rupture. And for the neurointervention, when we treat the aneurysm within 24 hours, we have many benefits. Firstly, we can treat easier than the days after, because within 24 hours, we normally the vasospasm is not, it does not occur, not yet occur. So we treat by endovascular easier. And the second benefit is we need to include the rupture aneurysm. Is for the medicine doctor can use many techniques for the treatment. Example, 3S method, like the hypertension, hyperdissolution of the blood. So it's better if we treat the aneurysms within 24 hours as clipping or coiling. Thank you.
Okay, thank you very much, Professor Trần Tuấn Anh. Next, I would like to invite Dr. Chi. Dr. Chi, can you hear me?
Yeah, I can. Thank you, Professor, for inviting me. Thank you, Dr. Kinh and Dr. Cường, for your value and wonderful presentation. First of all, we talk about the new guideline for management aneurysmal subarachnoid hemorrhage. What the new thing for new guideline? They emphasize some new thing we focus on. They press the aneurysm should be treated in the center with neuro ICU and the center who have a higher K of volume. As soon as we diagnose rupture aneurysm, we should send patient for treatment within 24 hours to exclude aneurysm. Then we can send patient to ICU for treatment, like we prevent DCI, we treat complication after subarachnoid hemorrhage. And the thing is, we need to concern about the choice between neurosurgeon and neurointerventionist. So look through the guideline based on ISAC. We can see overall result for embolization is for the short term is much better for patient who underwent coiling. For the short term, in 1 year, the mortality and favorite outcome is a better choice for embolization. But for the long term, in 5-year results, we can see this re-rupture rate is high, re-treatment rate is high for patients who underwent embolization. And then we can see through the guideline, this shows us that in some subgroup, we should see some recommendation for patient, for old patient or for young patient. Right, the group for patient, you can see for young patient, especially patient under 50 years old, we must think about longer life expectancies, and then patient better have surgical clipping instead of embolization. And some subgroup, ISAS, the lucky as RCT shows us both coiling and clipping by individual with expertise in endovascular and surgical technique is depend on the center who has expert between neurosurgical clipping and neuro interventionist. This one is better. If you what we call, if you think we do surgery is better than coiling, then we go for surgery. If it's balance between two groups, the first choice would be embolization. That's a concern about what we talk about new guideline. And then for embolization, for treatment of giant aneurysm, is really difficult. When patients are diagnosed with giant aneurysm, the risk of rupture is 50%. The mortality rate is 68% to 100% in 2 years if patient untreated. Then when we diagnose this giant aneurysm, we need to treat patient either surgical clipping or bypass or embolization. With giant aneurysm, recently coiling is not suitable because retreatment rate, recurrent rate is really high. It's more than 30 to 33%. And then since flow diabetes stent have allowed, the trend would be changed. The first choice would be diabetic stent. If patient is unsuitable for flow diabetic stent or failed flow diabetic stent, bypass will be the last choice. We can do either high flow bypass or low flow bypass. It depends on the result of balloon test. If patient pass balloon test, we can sacrifice ICA and we can do low flow bypass. Why we do low flow bypass? If patient pass balloon test, it still remain 10 to 30% of delayed ischemia, cerebral ischemia. Therefore, we need to do low flow bypass. Is safe for patients who fail balloon test. We concern about high flow bypass, but the problem is the mortality of high flow bypass is high. The rate from 8 to 13%, and then high flow bypass, it can be seen a rescue technique and the last choice if we cannot do embolization. Thank you.
Okay, thank you very much, Dr. Chi. And now I would like to invite Dr. Hiệp. Dr. Hiệp, please.
Yes, I'm here. Thank you, Professor, for today. A very special and very special meeting. And I'm sorry, just okay. Because you are talking about aneurysm and emergency problem issue in neurosurgery, in neurology, neurosurgery, and multiple discipline, especially surgery and intervention. You have today two very special and very interesting presentation, because for the first presentation of Dr. Kiên is about 2023 guideline, and as well as I know, is this guideline is just published the May 22, 2000 this year, and it's not yet officially published, and the day the official day of publish it will be tomorrow. That means you are discussing about an article of future, okay, and I think it's very long guideline with 57 pages. And very new. What news in this guideline? This guideline is replaced 2012 for the same subject. Why this guideline, and why this year? Because after about 10 years, you have new evidence you have new chain, and you have new amelioration in treatment of patient. And as we know, it's a very, very, very a hot topic. It's always for neurosurgery, because rupture of aneurysm is every day. Okay, and this I'm sorry. This guideline is based on a new study from 2012, just today. It's about the news about level of evidence, class of recommendation, and etc. and some many other. And the most innovation in this guideline is Ottawa's Subarachnoid rule, because this is based on an article of a group of Canada, 2010, and because the accessibility of this rule, and they have to identify the patient with subarachnoid hemorrhage without any sign in CT. So it's very, very useful, And I think this guideline, as presented by Dr. Kian, you need time to read again, and you have a discussion later, because there are many things you can do with this guideline. You can do with this new chains of innovation and etc. And after 10 years, the technique in interventional in treatment of aneurysm are changing, many. Okay, and you think you have to get up to date in this area. And that's all. That's all. Is my comments. And I think Dr. Kian can share this article for all of our member of our society, and you can learn many from that, because you can take point in the emergency management of the patient. This can be published by Associated of Hearts, American Heart Association, and American Stroke Association of USA, but is can use in Vietnam, I think, because the evidence of science in neurology and neurosurgery and intervention are changing, and I think that's all. Yes, that's right. And for the second presentation, it's very difficult. It's very difficult because giant aneurysm. Last week you had a presentation, Dr. Hai, with surgery of giant aneurysm, and today you have intervention for giant aneurysm. There are not many cases in the world treated from 2000, from years 2000 until now. It's not maybe 100 or or something, but not millions cases in all world. Okay, so giant aneurysm can treat it like individualism in medical treatment. That means for each patient you have different of your own approach to treatment. Okay, so giant aneurysm, I think that means not only it's not only one specialty can resolve own aspects of that own issue in this topic, and I think you have more co-diagnosis between two specialty for treatment. And I have some question. No, I have a second comment about this because for technique surgery, they have several techniques like clipping, trapping, bypass, etc. And in the interventional, you have also parent artery occlusion, coembolization, reconstruct option of standing, flow converter, etc. That means there are a matrix of technique, and you have to choose the right technique for the right patient. That's all. And I have a question for second presentation. Isman, you have the step of diagnosis of giant aneurysm is the dimension of 20 millimeters. That means it's about 20 and 30 millimeters. You have mixed surgery or intervention, and I want to ask the presenter, what's the dimension you most frequently for giant aneurysm do you hear as a patient, and you can treat successfully? And the second question is, by which criteria you choose what technique for giant aneurysm? That's all. One thing, I have agreed with Professor Tuần because I have been accumulated to get update about treatment, and the chain of treatment here is balloon and stent diameter. Yes, I agree with that. So I repeat, my question is first thing is what are dimension most frequent have been used in treat successfully for patient? And the second question is which criteria of for choosing of in treatment? That's all. Thank you.
Okay, thank you very much, Dr. Hiệp. And there are some questions. Do you have some question for Dr. Cương and Dr. Kinh, please?
Hi, Professor He. I have two questions.
Yeah, please.
One's for Professor He. Do you often do a high flow bypass for giant aneurysm in your center?
No.
Yeah. And the question for Dr. Cương. Do you find any difficult to do embolization in patient with MCA aneurysm, do you often do embolization for that? Just either coiling or either coiling or stenting?
Dr. Kung, please.
Yes, thank you for the questions. I will answer the two questions of Dr. Hiệp first. About the first question of Dr. Hiệp, which dimension we, these interventionalists, care about when evaluating the giant aneurysm? In the define, according to the literature, they doesn't mention about the particular dimension. So I think based on the define according to the literature, if an aneurysm has a dimension hair size more than 25 millimeter at any dimension, it's called a giant aneurysm. From the interventionalist aspect, if a giant aneurysm has the height is way more bigger than the neck, it may be easier to treat than the one with the height is less than the neck. And the second one, the second question of Dr. Hiệp, which criteria we can when choose the treatment? I think it depends on case by case, such as when is there aneurysm rupture or unrupture. If unrupture, the aim to prevent recurrent bleeding. So we will choose selective coiling. Maybe we cannot occlude totally the aneurysm as the first intervention. It's no problem. The aim of first intervention with a rupture in the aneurysm is to stop bleeding. So maybe we just occlude the dome of the aneurysm and follow with the strictly follow up and do intervention additionally if necessary. And another example, if it's unruptured aneurysm, we prefer parent vessel occlusion. If the BOT balloon occlusion test were passed, and if the balloon occlusion not passed, we have the choice of a flow diverter stent. And the question of Dr. Chi about the difficulty when do coiling or stenting the aneurysm in MCA segment. It's a challenge for the interventional technique, because if we coiling the aneurysm at MCA usually has a wide neck, and each coiling is we have to use the balloon or stent to assist the coiling, and it's difficult in more difficult in technique than the small neck one. If we choose to place stent, it's also difficult too, because of the structure of the MCA. You know, the aneurysm often arrive from the bifurcation of M1, M2 segment. So at this position, the parent vessel has a smaller in dimension than the ICA, and the parent vessel usually kinky. It's hard to difficult to place a stent diverter in this case. Yeah, thank you for the question.
Yes, may I have some comment, please?
Yeah, please.
Yeah. Thank you for the comment and the kind words from Dr. Chi and Dr. Hiệp also. And I totally agree with Dr. Hiệp. This guideline is very new. It's published in the May of the Stock Journal. And in this guideline, in my opinion, we have some focus in diagnosing, preventing some complication and nursing. For example, for the diagnostic, the aneurysm, this guideline say something that the Ottawa rule and the lung function. I think two methods is not common in my country, in Vietnam. So especially in this guideline, they also writing out big but not that. So non-contact computer tomography must be interpreted by the neuroradiologist, not the general radiologist, and so the team treatment should be interventional, not the general interventional like in the previous guideline. And they also focus to prevent to most dangerous complications of the rupture, that is the DCI and the rupture intraoperative. So many research focus on the medication new approach to prevent early diagnosis of DCI. And this is the first time the invasive neuro monitoring is make in this guideline, and also control the rupture intraoperative using medication that name adenosine make occur in this guideline. And one of the most important thing, in my opinion, that is the nursing care. I think that maybe it is the first guideline from the doctor in the management confirm the role of the nursing care in the guideline of treatment of neurosurgical disease. Also my comment. Thank you.
Okay, thank you very much, Dr. Kiên. And now we have some doctor from doctor who work like a radiologist and she do embolization, and most do like a neurosurgeon. And the question is long. It's conflict between the neurosurgeon and radiologist. What is advantage for the embolization and disadvantage of embolization in the treatment of aneurysm? I ask everybody. Do you prefer to do embolization or do you prefer clipping? And why? Can you hear me again?
Yes, I can hear you. That is, in my opinion, this is a very difficult question. I think that is the answer for this for your question is also the answer for the question why for 2 years, he searched the third guideline for the management of rupture aneurysm. And in my opinion, I think that choosing the treatment for the rupture aneurysm should be depend on the patient characteristic, the aneurysm, and the hospital that can do the open surgery or endovascular. Thank you.
Okay, thank you. And how about Professor Trần Anh Tuấn? Okay. And how about Dr. Cương, please?
Yeah.
Yeah.
I think it's a classic but a tough question. For me, as a neurointerventionalist point of view, I think it depends on if the aneurysm is unruptured and the anatomy structure of the vessel is suitable for under intervention. I will choose the intervention over the clipping. But in some cases, due to the limit of technique, when compared to the structure anatomy, we simply cannot perform intervention embolization. So in those cases, clipping is preferred. And when it comes to rupture aneurysm, it's complicated to say. And I think with rupture aneurysm, we had to make a decision case by case, and maybe a council include the neurosurgeon, neurointerventionist had to work up as a team and make the decision with these cases. Thank you.
Okay, thank you very much.
And what about your opinion, Professor Hay?
Yes, I think sometimes in some, it depends, of course, it depends the patient, it depends on aneurysm, it depends a lot of factors. You can decide, you can clipping, you can do clipping, you can do embolization, but the doctor have to know which method, which treatment is best for the patient. But sometimes in practice, I see I think nowadays I see if the doctor would like to do clipping, they try to explain to the patient, maybe clipping is better than embolization. If the doctor would like to embolization, they try to explain to the family, embolization is better than clipping. I see many, but of course, not every doctor do like that. And the second one, I see some hospital, if the patients come to the neurosurgical department, the doctor prefer to do clipping. If the patient sees a radiologist, they prefer to do embolization. Or sometimes in the hospital, if they do more embolization, if they have more experience to do embolization, they try to explain to the family, embolization maybe is better than clipping. It's happened everywhere in the world. In Europe, in USA, in Asia, it's the same. For me, the doctor have a power we need to explain to the family. There's something we need to remember. If you would like to do embolization, or we would like to do clipping, is based on we need to talk about evidence base, not experience. But it's not easy, I know. It's not easy. I know everybody can talk easily about the advantage, disadvantage of clipping or embolization. But one time when we see the patient, how we explain to the patient, how do you talk about the treatments to the family? It is more important things. We cannot control everything. No one can control the doctor. The direction, the director, the chief of department, everybody cannot control the doctor. The doctor have a power to decide which one is better for the patient. It's happened everywhere. I see everywhere. Overseas. Everywhere is like that. And in every specialist, like in spine department, somebody would like to make surgery, but the other don't. Somebody would like to make fusion, fixation, the other don't. I don't know, but it's up to the doctor. Doctor has the manpower is doctor. Doctor decide to do something and he try to explain to the family that this is something happened, but I don't think this is the right way. That is my opinion. Thank you.
May I speak now?
Yes, please, the doctor here, please.
Yes, I'm sorry because your question I was not very attentive, but I have I remember a question about the first presentation of Dr. Kian with someone was agree with the treatment of aneurysm between first 24 hours. And it's not new because as many people come to the foreign country like France or in Europe or in USA, the treatment of aneurysm in the first 24 hours is usual, is standard. And can you, Dr. Kian, please, can you talk something about the news in this 2023 guideline for this point, please?
Yes, I totally agree with you about the kind of surgery. In this guideline, the writing author confirm the benefit of treatment within 24 hours with the high level for the previous guideline. And as you know from the previous guideline in 2012 up to now, we can see we can find a lot of research to make the comparison, the benefit of surgery, rupture aneurysm within 24 hours, and the result of this method is over than treatment from the 22 to 75 hours. That is the reason why in this guideline the level of the timing of surgery within 24 hours is accurate than the previous guideline. This is the new in this guideline.
And do you think is is obliged is the standard to treat the patient with a rupture aneurysm between 24 hours, because as we know, is our health system cannot adapt or can be response to this require is quite difficult to treatment on the ruptures aneurysm between the first 20 hours. And yes, do you think you have to standardize this criteria?
Yes, I think that is really valuable in some hospitals, such as the Việt like mine or my hospital in Buenos. As you know, in this guideline, the author success that the patient with rupture aneurysm should be treated in the high volume hospital, and I think that in the high volume hospital like Việt like my chảy or sample like this, the treatment for the rupture aneurysm, not only surgery or endovascular within 24 hours is possible. And I remember that I read a research about 2 years ago. They said that only when each patient who severe, for example, the WFNS or Hemorrhage grade 4 or 5, they should be delay for medical therapy with the purpose to improve the clinical the clinical of the patient. But with the patient with good grade ASAH, I think that the repair of the rupture aneurysm within 24 hours is valuable in Vietnam. This is my question. It's my answer. Thank you, Dr. And in my opinion, one of the most important and dangerous in Vietnam for delay the timing of surgery, that is the decision of the family of the patient. Sometimes it is difficult to explain for the family member of patient to accept for the rapid treatment of the rupture aneurysm. Thank you.
Okay, thank you very much. I just asked everybody about which is better, embolization or clipping. For me, now it is more important thing if the surgeon have to work with the radiologist together before decide to make clipping or to make embolization. Both of them have to discuss together. It is something we need to do if we try to decrease some mistake to indication. If the surgeon work alone or radiologist work alone, sometimes make mistake. Even we think about, but if we work alone, we can get some mistake. If we work together, we can avoid the important mistake. Everybody knows that if we do even the best neurosurgeon can make the important complication, and even the patient die, or the best radiologist can do some important mistake, even die, even patient will die. And that's why I think if we can go together, it is the best thing for the patient. It is my opinion. But sometimes it's not easy. I know that. But I think it is the best way to avoid the big mistake. Thank you. Do you have a more question or more comment? And I have one question for Kinh, because the is you talk about the guidelines, and how do you think if you can do the same thing in Vietnam, or if you can do, I don't know, we can have some difficult, and how you can do that, how you can apply, or how you can modify something, or how?
Yes, I think that the Vietnamese version guidelines for management of the rupture aneurysm will be available. I think we can translate and modify to adapt the condition of my country. I think I'm very happy if we have the guideline for our patient in Vietnam.
Yes, excellent. I think it is a very good answer. It is not easy to get a guideline for us. It's not easy, because I don't know, maybe it's 6 months ago, I asked, I would like to have the guideline for the head trauma, for the TBI. And the second guideline, I would like to have the guideline for the hydrocephalus. The third guideline I would like to have, it is for the spinal trauma. And we talk about the aneurysm too and AVMs, because some things happens in everywhere. You know that you can see the hydrocephalus in everywhere, in the mountain, in the province, in the big city, everywhere. And we can see the TBI everywhere. You can see the spinal trauma everywhere, and we can see the aneurysm rupture, AVM, the hematoma because of AVM, subarachnoid because of AVM everywhere. And if we can have the guideline for some emergency cases like that, it is very, very good thing for everybody, for the patient and for the doctor. But as you know, I asked 3 groups. One group developed the guideline for the TBI, one for the spinal trauma, and the other for hydrocephalus. But up to now, I think maybe 6 months, no group asked me to present. I don't know if they have the final version, but I don't know. But nobody tell me what's that. And in the beginning, they told me that maybe 3 months, but up to now, maybe 6 months. I have no answer. It is not easy, I know. But I think some can do, maybe we can do the first version, so we can discuss together, and we can get the second one, maybe third one, I don't know. But if we don't start, we cannot finish.
Yeah, I agree with you.
I think you can start with aneurysm rupture. I think maybe rupture for the unruptured aneurysm maybe later, because the rupture is very and now you can see I can see many every week I meet people with unruptured aneurysm, and they find me to ask question if we need to treatment, if we need to do something, and yeah, it's so much because we have too many CT scan and MRI everywhere. Yeah.
I have note, please.
I would commend that.
Yeah, Chief. Yeah.
Professor Hebb from Vietnamese Neurosurgical Society.
Yeah.
We better choose the guideline from many different topics, and we present it, and we save every people know every neurosurgeon. We better follow the guideline, and it depends on each center. We may follow, it's not all, but we follow some that we can do. For example, for rupture aneurysm, for the big center, like the hospital, but my hospital at the right hospital, we have two teams between neurosurgeon and neuro interventionist. We can have two teams, we talk together, we work together, we say each other, then we decide which one is the best option for patient. But some hospitals, some of the center, they have only neurosurgical department. They don't have a neuroradiologist, and they don't have a neurointerventionist. And the number of case for clipping may higher. That depends on the center. But when we have two teams, we better follow the guideline, and we choose a good option for patient. For example, patient with rupture aneurysm admit to the hospital. If the patient have a wide neck MCA aneurysm, I would choose surgery. I don't recommend for coiling. I will decide it and explain to the patient. However, if patient with a paraclinoid aneurysm, I would touch patient. I will recommend, I will prefer, I will say for neurointerventionists to do either coiling or stenting. For example, 2 days ago, I performed one paraclinoid aneurysm. It's rare recently. For 5 to 10 years ago, I did paraclinoid aneurysm quite often, but recently I do very rare that case because this is a difficult case. It's a high rate of complication, and it takes a lot of time to do that. So that I recommend that we follow the guideline. This one is a better choice for embolization, which is we say for neuroradiologists. However, in the case suitable for surgical clipping, I will do clipping. Yeah, thank you.
Okay, thank you very much, Dr. Chi. Yeah, this is it is a good idea. I agree. And
may I have a note, please?
Yeah, please, Doctor. Here, please.
Yes, I'm very agree with the Dr. Chi. It's a very interesting idea, and but it's sometimes very difficult because it's a spread like you have multiple center. But I think the first step you can do is as I talked before, you can do a meeting. Because today you we have to talk about giant aneurysm, for example. You can have a meeting, multidisciplinary meeting, for example, weekly or bi-weekly or 1 month, or once a month, for the complicated cases, and for the cases treated successfully or even unsuccessfully, because with that meeting you can learn many things, because when the patient come hospital, the information or the experience, medical experience of that doctor is just stay in that hospital. It can sometimes difficult to share information, and you can learn from that. And I think with a kind of meeting, you can, especially for the difficult case in aneurysm, so you can learn each other for treatment, and it can be more easy to use the guideline in the every hospital. Yes.
Okay, thank you very much. But I think, Kian, I think you can you present about the guideline, and you can modify the version for Vietnam. And I think when you finish, you can present. Maybe I will organize a committee. I think we need to have a committee on that. We can work online, not the webinar like that, but we can work online together. I can find someone from Chile, from South, like Dr. Chi, Dr. Chung, for example. You can find someone from the middle, Da Nang or Huế. You can find someone from the north. You can organize a committee. Even when you finish the version, we will discuss together. I don't think one time you can finish. You can finish maybe in some weeks, and we can discuss together for the first version, and maybe we can organize maybe 10 times, maybe 5 times. I don't know, but it's not easy. But we need to start.
Okay,
Yeah.
I will try my best.
Okay, because maybe for this group, for the other, maybe they would like to get the best version, and that's why maybe they don't show us so early. And the second thing, for example, the guideline for the TBI is very complicated. For the severe TBI is different. For the guideline for the children is different, and maybe it's more complicated. And so don't forget, in Vietnam we have some big city, like some big hospital, like for example in Saint Paul you can do clipping, you can do coiling, and the other province, for example, in Bắc Ninh province, it's difficult to do clipping, but sometimes they do coiling. And the other kind of hospital, like discipline hospital, they cannot do embolization, they cannot do clipping, and also for the, how can I say, for the paramedic, they need to they need to know something, and they can decide something, for example, they can where they will transfer the patient. The right hospital is okay. Something is a good thing for the patient, right? And it's not easy for the paramedic. In Vietnam, there's a lot of things to do. Even now for the spine cord trauma or TBI, the paramedic, maybe, I don't know, it's not easy. Okay. Do you have some more question or Dr. Yep?
No, please. Thank you.
No. Okay, Dr. Chi, please. Do you have?
Yeah. Yeah, it's late right now, but if we have time, I would talk about, giant aneurysm, because I'm a neurosurgeon. I did some giant aneurysm for surgical indication for giant aneurysm, different technique. We can do microsurgical clip reconstruction. For example, is MCA giant aneurysm. It's not suitable for embolization, and I often do reconstruction. And for high flow bypass is failed embolization. It's not suitable for embolization. I do high flow bypass, but the big concern is on my hand. I have 25 case high flow bypass, but complication is not low. However, I have a 3K is giant aneurysm. This part balloon test, and I would do ICA sacrifice in low flow bypass, but low flow bypass is safe. Patient, I have only 3K low flow bypass for giant aneurysm, and I didn't do deep hypothermic circulation arrest technique, but I observed once in Singapore General Hospital with Professor Ivan. Yeah, Professor, I know him well, right? Look through literature reviews, the complication rate is high in Singapore General Hospital. They did only one case. Recently, when I met Professor Ivan, I also asked him any more case that he did surgical clipping with deep hypothermic circulation arrest technique, and he told me that he did only one case. That's 1K experience when I did my fellowship in NNI. For giant aneurysm, it's a difficult topic for all of us, including neurosurgeon and neuroradiologists. Yeah, that I would say with you.
Okay, thank you very much, Dr. Chi. Yeah, yes, it's very difficult for the giant aneurysm, and it's not so many surgeons have a big experience like you, Chi, and I think it is interesting to if you can present some things to show us and how you do, and it is very interesting things. And maybe next time you can share with us. See,
I'm ready. Anytime I can share with you my experience in surgical for giant aneurysm, as well as surgical technique for clipping, because I found some complication in clipping technique. Sometimes we may narrow the parent vessel, or we may leave the neck of aneurysm. Yes.
Yes, these are things. And you know that on the webinar every Friday evening, there are many young doctors, and that's why it is a good thing if you can show them how you can start to do with the easy case for the beginner, right? You can you can show them how you can do for the easy case, and that means for the young and for the people who come from the province and far from the big city, and some hospitals they would like to do clipping, and if you can present something like that, it is one day, another days you can show them the more complicated, more difficult cases like a giant aneurysm. It's okay, and I think you can present something like that. It is very, I think, a very good thing for the useful for the young, because the most of the people, most participants of our webinar is young, and it is something is good for them.
Yes, so later next time we present it from the beginner. Yeah.
Okay. Thank you, Matichi. Okay. Do you have something? Some question, Kiên, Cường, Kiên Cường, yeah.
No, please. Thank you.
Okay. Thank you. How about Kiên? Okay. Okay, I can close. Okay.
No, yes, I'm okay.
Okay. On behalf of organizer committee, I would like to thank very much Dr. Cường and Dr. Kiên, who have a beautiful presentation today. And thank you very much, Dr. Chi, Dr. Hiệp, and Dr. Anh Tuấn. Thank you, everybody. See you next time. Bye-bye.
Yeah, see you. Thank you, Professor.
See you next time.
Bye-bye.